Welcome, everybody. I'm David Blight. I'm the director of the Gilder Lehrman Center for the Study of Slavery, Resistance, and Abolition at Yale University. Here we are at the very end now of the coronavirus semester. The Gilder Lehrman Center has for at least 2 years now been running a series, and we're up to 40 or 50 of these now, podcasts with our visiting lecturers, our fellows, and many other people who passed through Yale about all kinds of aspects of the history and particularly the legacies of the story of slavery and its destruction across all time and all borders. We're going to start a new variation of that series here for the COVID era, if that's what we're living through. And we're going to start today with a wonderful guest, my colleague in both history and African American studies and in the history of science and medicine at Yale, Carolyn Roberts. Carolyn did her BA at Dartmouth, her MA and PhD at Harvard in the history of medicine. She is a scholar of early modern medicine. She is working on her first book, soon to be done, entitled To Heal and to Harm, Medicine, Knowledge, and Power in the Atlantic Slave Trade, particularly the British Atlantic slave trade. Welcome, Carolyn, and I'm so delighted to be able to do this with you.
Thank you so much, David. It's wonderful to be here.
You bet. Let's start with the history, because that's what we both are.
Yeah.
And I would say at the outset, we're going to do some serious history here about your work, about medicine and health issue, healing questions in the history of the slave trade and the transportation of African peoples to the Americas. But we're going to work our way up to this current ubiquitous question now of racial disparities about health in American society. But let's go right back to your work, your research, which it was done, as you like to say, all over the UK, in all kinds of dusty old records. A story in some ways hidden in plain sight when you knew how to dig in the right archive. And what you've been after in this story is to try to understand not just the scale of disease, which is vast and terrible in the nearly 400 years of the slave trade, but you've really been after this question of what did Europeans learn from Africans about medical practice, in part because they had to survive. Could you lay out some of that, the nature of that research and the kind of story you've been able to tell?
Thank you so much. This has been a broad-ranging research project, and one of the ways that I like to describe it is that it's an examination of the intercontinental medical management of the British slave trade, meaning that we're thinking about how drugs are getting on board, apothecaries, chemists, and druggists contributing to a kind of global pharmaceutical dimensions of slavery and slave trading, the role of surgeons and their knowledge in really trying to understand the limits that can be placed on the human body in order to create them as human commodities and vendable goods. And so what is the role of surgeons in that, and looking at British surgeons? But then also, as you said, West Africa. West Africa functions as such an important place for the gathering of knowledge, of medical knowledge. And so when the British first arrive on the West African coast, one of the things that they're trying to do is figure out how they can stay alive, because now they're being faced with diseases like hyperendemic malaria and yellow fever. That they
and their death rates were horrific.
Horrific death rates.
Their life expectancy on the west coast of Africa was what? Only a matter of a few years.
Yeah, it was between 1 to 5 years for a large percentage of the new arrivals. And so one of the things that they did, which is an important part of the book project, is they enslaved people at their different slave factories and forts to be stationed there to care for the British and as well as for the West African people that are being shipped into the traffic and being sent across to the Americas. And so I study different, they were called doctors and doctresses. They were also called, some of them were called fetish women because of the spiritual dimensions of the kind of medical care that they were giving. And so the historical research has been so challenging because the sources are very limited, which is something that I know all historians sort of push up against the limits of the archive. In this case, we have lists of African healers, their names, we have their roles. We learn that they are doctors, that they are doctresses, that they're surgeons' assistants and other things, but we have very little information about some of the medical practices that they were carrying out. And so in order to get at that, I've had to comb through a lot of slave trade surgeons' correspondence, as well as travel narratives. I have to look at the natural world a good bit because a lot of these, especially the women who are doing the bulk of the healing, they were also working as agriculturalists in these slave trading zones. And so they're planting all of these plants and produce that would be used for healing. And so thinking about the ecological world, thinking about the medicines that are coming from the rainforest, looking at the different practices for enslaved people that are being trafficked from Senegal and the Gambia to Ghana. What different kinds of medical knowledge are people bringing? What different relationships do they have with plants? Do they have with the gods and the spirit world? How are they learning medical knowledge? And so, one of the communities that I study from, which is from the 17th century, they were on the Windward Coast. One of the ways that everybody learned about the plant knowledge in their communities was through oral recitation of all of the medicinal plants that the community used whenever somebody died, in order to see
that was part of a funeral ritual to name the medicinal elements that had been used as though they were giving thanks to, or
well, in some cases giving thanks, and in some cases inquiring about whether the person had been poisoned by one of these plants. And so it was a very long sort of recitation of every single medicinal plant that was known in their community. And so,
so that's good for research.
It is. It's very good for research. But the quest for this knowledge was really extraordinary. One of the particular moments that stand to me is how the British during the 1720s, they decided that they wanted to try to get as much medical knowledge as they could from all of the enslaved people who are coming from the interior. And so they put together a list of questions. And the list of questions asked them about the kinds of diseases that they had, where they were from, how far away they had, their communities were located. And if they knew of certain plants, they sent over plants from Britain to see if enslaved people recognized them and use them in their own healing traditions. And so they were hoping that they would be able to gather all of this knowledge before enslaved people were sent on these ships to the Americas. But the way that it gets particularly strange and interesting to me is that if there were enslaved people that the British thought knew something, but nobody could understand their language, they don't send this person into the Atlantic traffic, keep them in West Africa, keep them at places like Cape Coast Castle, so that they can eventually learn enough of the languages that surrounded them, whether they were African languages or English or some combination. so that they could eventually get this knowledge. It
Hmm.
speaks to the kind of the real quest and desire that they would go to such great lengths in order to capture the knowledge that African people had and which they brought with them to the Americas.
Well, that's yet another dimension of how much the slave trade was a colossal business. And at each stage of its development, they obviously were doing what it takes to maximize their business. And I don't know if it took them a century, but by the 17th century, the British had been at this for a century. So they're actually valuing now the knowledge and therefore the labor that can be passed on to British agents, or for that matter, by the Africans themselves who might get transported, because they're fully aware at that point they've got a massive disease problem. If they didn't know it by then, they would never know it. But they got a massive disease problem, and they need Africans to help them to solve it.
Yes, absolutely. And so you see in the Philosophical Transactions, which is the Royal Society, England's Royal Society, it's their publication. In 1697, you have an article that is published called A Collection of Some Guinea Plants. And these are plants that John Smith, who was a chaplain at Cape Coast Castle, sent to James Pettifer, who was a member of the Royal Society, after this chaplain at Cape Coast Castle had learned how to use every one of these plants for diverse kinds of healing, for dysentery, for hemorrhaging, for headaches, for stomach aches, for nervous disorders. And so he tells James Pettifer about what parts of the plants you're supposed to use, how you're supposed to prepare them, very detailed kind of knowledge. Plants that are dried and then sniffed to cure headaches, and other things that are boiled and made into different unguents for different sores and aches and pains. And
we're not talking here about just magical medicines. We're talking about tried and true methods that, let's face it, had been practiced for probably centuries, and then repracticed and experimented with and failed and succeeded, which is what science does. It fails and it succeeds, whether they called it science or something else. In your writing and your lecturing, you make an interesting case. This may help for people out there that don't know all this history, but they've at least heard of these great slave forts. I mean, the whole west coast of Africa is full of them, but Cape Coast Castle is probably the biggest. And I happen to have been to that one. I've seen it. And it sits there as this giant fortress. It looks, it looks very old, which it is, but it also looks so permanent. I mean, it looks like what it is. It's a giant fortress. But you point out that these were also essentially hospitals, right? I mean, that they functioned as hospitals trying to help people heal to be put into the ships.
There were moments when every single space was being used because everybody was sick.
Yeah.
So there are lots of letters that are going into London from West Africa talking about the great mortality, the great death, the great mortality, the great death. And it's almost like a ritual kind of incantation. It comes across so much in the letters. And so you have enslaved people that are being sent across the Atlantic that are being held in underground slave dungeons and being cared for by these enslaved healers. But some of these West African doctors that are practicing, I can trace them for 25 and 30 years. They're practicing there. And they are having to learn themselves new kinds of how to use new kinds of medicinal goods that are coming from the British context as well. So things like raisins and English lettuce, and these things that the British are having them grow because they're considered to be nutriments, which are being given along with maize porridge and coconut water and and papaya seeds in the
Was
case of
was
worms.
coconut butter somehow used for, I don't know, dysentery or stomach ailments, or
Oh, coconut water.
coconut water?
So the coconut
Yeah,
milk, yes.
sure.
But yeah, I don't see very much coconut butter in
Oh,
the
okay.
period that I'm looking at, but there is a lot of palm oil that's being
Mhm,
used in the
mhm,
way that you're imagining,
mhm,
for stomach ailments, for anointing the body to help with frayed nerves,
mhm.
and those kinds of practices were things that those that were held in these underground dungeons, where
Yeah.
they are defecating into tubs that are overflowing and having vermin nibbling at them.
Mm.
That there were moments when these enslaved doctors and doctresses would come into these spaces and try to care for them, in whatever ways were possible.
Did they practice or understand quarantine? I mean, what the practices of quarantine are not just modern.
Yes.
They must,
I,
although the chance to practice that was, of course, very limited in a fortress
yeah, the
with
in
captive people. We have to remember.
That's right. That's right. They are. They are captives. And in some of the travel narratives that I've read of Europeans that are in West Africa in the 1720s and 1730s, one
Yeah,
doctor, Dr. Thomas Aubrey, he talks about quarantine. He
yeah,
says that when the enslaved on the Gold Coast are sick from certain diseases, they go by themselves into the forest.
yeah.
And people will go and they will drop different kinds of goods, foods, and things for them.
Right.
But they will go into the forest and they will come back healed. And although he didn't know exactly all that went on in the forest, he noted that it was a time of quarantine. So
Mm,
keeping people away. And there's also an understanding of quarantine in terms of diseases like leprosy,
mm,
where people were outside of the communities. And so these were very old, long-standing practices.
yeah. We so often now talk about the slave trade as the obvious, utter commodification of people, commodification of human beings into pieces of transferable property. But part of that commodification story is also this medical story. I mean, you're trying to codify people or commodify people, but you're also trying to keep them alive. You're trying not to spread disease. I mean, this is a hideous, hideous system, but all those calculations are not just about how valuable is this body, but it's about how do we keep that body alive? And how do the people doing the enslaving stay alive in such a disease environment? Um, and on the slaves, there's a quote I've always remembered from a book in the 1970s, and this may get us across the Atlantic if you like, but it was in Vincent Harding's book back in the 70s called There Is a River. Vincent was an African American theological historian. He was a theologian historian, but in this big general history he wrote of the African American experience, he called the slave ships, and your work just reminded me of that this morning. He called the slave ships the cramped and fetid waiting rooms of history. Waiting rooms, which makes it sound like a medical facility. It makes it sound like, a hospital where people are both living and dying.
Yeah,
Waiting
that's right.
rooms of history.
That's right.
So say a word, if you can, about the nature. I mean, the slave trade involved now, we believe, between 35 and 40,000 documented voyages over, I think you say, 366 years of the slave trade. Most of that trade going to south of the equator, not north, but masses of it going south of the equator and then to the Caribbean, of course, and then ultimately later to North America. It's one of the cruelest filters of human beings we've ever known. Largest forced migration, oceanic forced migration in all of history. But it is a disease laboratory, isn't it? through which people do get filtered, if that's the right metaphor or verb, into new places with new diseases and new landscapes, where even the people, even the Africans with knowledge of healing, have to totally adapt all over.
Yeah.
Tell us something about that process, as big as it is. I know it's hard to capitalize, but
I think that one of the things that's so important in thinking about that transition is that for West African people and West Central Africans, but I focus more on West Africa. For West African people, their first contact with Western medicine is often happening on the West African coast and then on the slave ship. And so that kind of contact that they're having is one that is particularly violent and brutal. And yet at the same time, it's violent and brutal because they are trying to keep people alive.
Right.
And so the ship as this sort of waiting room, which is such a wonderful way of putting it, because this is a transition moment. And the kinds of encounters that enslaved people are having, which makes their arrival in the Americas and their desire to hold on to their own medical practices, I think, that much more powerful and potent, is because they're subjected to forced medical inspections on the West African coast, which can last for hours for one person, where women are pinned down and their legs are spread open and they're being examined, their vaginas, their cervixes, they're being examined in ways that observers say left them weeping uncontrollably.
Yeah.
To get on these slave ships, and doctors.
They're examined to demonstrate their reproductive capacity.
That's right, their reproductive capacity.
Yeah.
And once they're on the slave ships, doctors are in a place where the enslaved are trying to kill themselves because they're trying to escape, or they're trying to kill, and rise up in rebellion against the owners and the doctors. And so when they try to starve themselves, which happens so frequently, the doctors are beating them. And so to inflict wounds to keep them alive, that they themselves have to then care for the wounds that they created, force feeding them, breaking off their teeth, restraining them when they're trying to jump overboard or mutilate themselves with their own hands. When they try to jump overboard, the doctors are responsible for making sure that these things don't happen again. And so the doctors are threaded through that very violent space. And so when the enslaved are landing in the Americas, holding on to their own sort of knowledge of their healing cultures, I think that it wouldn't be a stretch to say that they're already trying to recover and heal from their initial experiences of Western medicine and encounters with these doctors in this medical management system.
You use a term in your work it's a scholarly term, but it does a lot. That what the healer, let's say it's a woman on a ship who survived, who's one of the maybe 75 to 80% who survived the voyage. I mean, we have average death rates on slave ships, depending on the period, the era, the size of the ship, et cetera, would often experience up to 15% death or more. But okay, she arrives. She's I don't know, wherever, Kingston, Jamaica. But she knows healing practices, and she's in this whole new environment now. Although there may have been things similar to the, say, Jamaican environment to part of West Africa, but she undergoes what you call a migrant or she practices what we scholars have come to call a migrant ethnobotany. She brings knowledge of plants. Now she's looking for plants that she can perhaps apply her knowledge to. Not unlike the African slaves who were looking for sounds, words, language, gods, religion, practices that they could connect to understand where they are. But it happens literally right out of the ground for how to heal too, right?
Yes, absolutely, absolutely. There's so rich scholarship thinking about what is the kind of interaction that newly arrived Africans are having with the natural world in
Yeah.
terms of plants that they might recognize, new plants that they end up substituting for home species they used at home,
Right.
knowledge that they're getting from the indigenous population, and the sharing and the back and forth of healing traditions and practices. And so it's there to arrive in a new land, to be suffering from even common ailments like
Yeah.
headaches and stomach aches and things like that, that they knew that if they had Malagueta pepper, they would be okay.
Yeah.
That if they could get their hands on some lime juice, they would be able to help heal ophthalmia,
Right.
eyes. That knowledge is coming into these new spaces. And one geographer, Judith Carney,
Yeah.
she's done such wonderful work. But one of the
She
things,
won the Frederick Douglass Book Prize one year for her book on the slave trade in botany. That was
oh,
that was like
it's
8 or 9 years ago. Yeah. Anyway, go ahead.
it's
Yeah.
such exciting work.
It's an
And
amazing book. Yeah.
yeah, and she's identified plants
How
in the,
botany got across the Atlantic on slave ships.
yes,
I mean, who knew?
that's right. And that they brought, that they had seeds with them,
Right.
that some of the foods that they're eating on board ship, because they're getting a lot of those foods sourced from West Africa, a lot of those foods are also used in healing, and that they're able to bring some of those things with them. But there's this one story of an African woman being put onto a slave ship, and before she goes, she gobbles the earth as
Mm,
she's being dragged away and tries to swallow it so that she can carry some part of that land with her
mm,
into wherever she's heading, parts unknown.
yeah.
And that sense of connection with the land and wanting to reground yourself somewhere in some kind of land, to have a place and home, is part of that. I think it's part of that wonderful scholarship that began happening when Vincent Harding was writing,
Yeah.
in
Yeah.
terms of how did
70s.
culture
Yeah.
figure as of resistance.
Yeah. No, that's what's so fascinating to me as an older scholar who, I came of age learning about everything we learned from anthropology, which was about syncretism, right? All that theory of how cultures encounter other cultures, cultures encounter terrible trauma, and they borrow and they draw here and they draw there in order to survive. That's what syncretism means. But we always studied it as culture for good reason. I mean, folk tales, religion, music, et cetera, et cetera, et cetera. What was still African about African American music when it comes out as the blues in Mississippi? Well, there's still something there. The blues beat, some musicologists say they can trace to certain kinds of Yoruba music traditions that came through Cuba and then into New Orleans and all of that. But this is a similar story, but it involves medical practice, it involves healing practices, and it involves botany. I mean, that same woman who may have been trying to ingest soil may have also had this is from your work, it's the only reason I know this. She may have also had in her mind the fact that if she could find the right bitter root or, the right plant, she could begin to help solve fever or stomach ailments, or she's also carrying that. It's that human capital in the brain that is so hard to see and to measure, but that's what your work gets at.
Yeah, it is. It's the sort of, thinking about the intellectual labor
Yeah.
that was so privileged. We think about enslaved people for their physical labor, not their knowledge. And yet, the example that you see on the West African coast with the British trying to access knowledge, and when you see the importance of enslaved healers on plantations, and that their knowledge of the natural world was so powerful that, you know, in colonial America, in places like South Carolina, they tried to outlaw the practice of slave healing because they were afraid of being poisoned, because they knew the natural world so much better than other people. And even, you know, when you think about someone like Edward Long and his writing from Jamaica, where, you know, he's sort of a, you know, infamously racist in his language, and yet he still acknowledges that the way that the enslaved people in Jamaica know how to heal is something that should put Europeans to shame, because they don't have the same level of knowledge.
Yeah. Not unlike the antebellum slaveholder would denigrate the basic humanity of his blacksmith, but be utterly dependent on that blacksmith.
Right. That's right.
To shoe his horses and so on and so on. It's a big leap, but can we transition to somewhat more modern times? I mean, for one thing, you argue here, as do historians of medicine broadly, that the slave trade and then the transition of this, you know, massive transition of people to the New World has a lot to do with the origins of modern medicine, or the modernization of medicine. How can we understand that into the 19th century, even into the later 19th century? Is there a connecting of the dots legacy out of this medical history of slavery that carries over into more modern times?
I would say that there is, and I've thought about this a good bit, partly from the prompting of medical school students and doctors
No?
when I describe my research on the slave trade, and especially the relationship between enslaved people and British doctors in the context of the slave trade. And I begin to think it forward. Doctors and medical school student lectures that I give will say, I feel like I'm living in the aftermath of this history. I feel like I can't believe I didn't know this history. Why didn't I know this history? Why isn't this history required
So
for
they're
me going
saying
into
that
medical school?
they're saying that from their empirical
Yeah,
eyes. That
they
I feel like
are.
seeing this, but they don't know
Yeah,
the history. Okay.
that's right. And
Yeah.
connecting thread, there's so many different connecting threads, but the one that I sort of land on as being one of the helpful ways of thinking about historical continuity in this particular case is the relationship, thinking about the relationship between Black people and American medicine, by which I mean the medical institutions, medical caregivers, and healthcare systems that have structured Black people's experiences of sickness and health. And so if you trace this history and think about, okay, we know what happened in the slave trade. We know about the kind of meditation. Well, when we get to the Americas and we get to the antebellum period in the US, it's very hard to look away from the fact that the rise of medical schools and the development of medical knowledge in terms of anatomy and pathology, all of that learning is taking place on the bodies of enslaved people.
Yeah.
Because they were the people that you could get for these experiments. They were
By design. Quite by
quite
design
by
in
design.
so many instances. Yeah.
Exactly. I mean, you can read advertisements in the newspaper about that, they have a plentiful supply of Black bodies for medical school students to use, so that they can do their experiments. We know about from Dinah Rainey Berry's amazing book, we know about this illegal cadaver trade that was going
Right.
all over the
Cadaver
country.
trade, yeah.
You know, of, you know, so not only in life, but in death, their bodies being used to advance medical knowledge.
Yeah.
Now think about what happens after emancipation, when you have the, you know, the rise of Jim Crow segregation in the North and the South, and you have diseases like tuberculosis that are ravaging so many places in the early 20th century.
It was the leading cause of death in the United States in roughly 1920 was TB.
Right? That's right.
Yeah.
And the
I only know that because my dad had tuberculosis, so we had to learn everything about tuberculosis.
Oh my. Oh, yeah, it was, you know, it was a devastating disease, but it was a disease of often of poverty.
Yeah.
And so a lot of the rhetoric at that time, why are Black people dying in such high numbers from this disease? Well, they're being forced to live right beside sewers where there's human waste flowing by, and the kind of rhetoric about, oh, people were not fit for freedom. Look at, they're dying in these high numbers. Or
the vast theory in the 19th century, our audience needs to know, the scientific theory of the incapacities of Black people to survive in modern environments. It's all over the culture, as you know.
Yeah, that's right. That's right. It's everywhere. And so blaming their habits, accusing them of laziness, of inability to sort of comply with basic public health practices, which is some of the same rhetoric we are hearing today.
Yeah, we're the rhetoric we're hearing in this very current discussion is sometimes a moralizing rhetoric, isn't it?
Yes,
it's not all. I mean, a lot of people point here to to poverty, to you know, poor people living in environments that are unhealthy, but there's a tendency. There was a recent U.S. senator whose name I'm forgetting at the moment, who is himself, is he from Mississippi, I believe? I should be careful with that. I'm not sure it's Mississippi, but who is himself a physician. And when he was asked about all these racial disparities on I think, national public radio, he talked almost entirely about habits, not about the economic structures, not about poverty, not about having to work when others don't have to work in a disease environment. Anyway, that moralizing rhetoric is very old.
Very old. It's very old. And so, you know, so this historical continuity in terms of the brokenness of this relationship, there's a fundamental brokenness of this relationship between Black people and American medicine, medical institutions, medical caregivers, and the healthcare system. It's always been fraught. It's always been broken. And at times it's been deadly. And so, you know, when we think about that same period of time with tuberculosis and then going right into, you know, the 1960s, we have a segregated health system in the North and the South. So that some, you know, a lot of the hospitals until Providence Hospital was started in Chicago, there was only one hospital that Black people could access in the entire city. And so the you know, having to get medical care in a segregated hospital, if you could get in, meant you were going to a waiting room that was a janitor's closet, and your healthcare was happening in a basement that was dirty and cold.
There's an aspect of the history of Jim Crow that people don't always think about. We think of Jim Crow as laws, we think of it as the suppression of the vote, and it was. But this is on the most human level. Jim Crow meant lower life expectancy, closer proximity to disease, lack of proper health care, and it meant Black medical schools.
That's right. That's right.
Right, Meharry, Howard, and many others, some of which, you know, trained a lot of great doctors, but they weren't part of the same medical system as the rest of the country.
And that's that other thread that goes through. So while we have this one sort of thread, you know, medical neglect and exploitation and real dysfunction in terms of this relationship of Black people to these sort of mainstream American medicine. At the
Yeah.
same time, all the way along, there's been health activism and resistance and caring for one another. And like you're saying, the rise of Black hospitals and medical schools, where you had African American women that were mobilized and throughout their communities, getting little bits of change and building it up until they had enough to help build a new hospital or contribute money to a medical school or a university. And all of that activism is also something that we are seeing today with, there's a Black female physician in Philadelphia who rallied Black doctors to bring mobile testing of COVID to the hardest hit communities in their cities. And in Chicago, there's Black Organizing for Power, which has been trying to do these community assessment surveys to figure out what's going on. And so you see the wonderful history of resilience and survival and all of hard labor from the grassroots up to survive.
And that history needs to be written and told as much as the history, the political history of civil rights, the larger economic history of civil rights. And again, Jim Crow is always a glass half full or a glass half empty. Were people able to build real community behind the curtains of Jim Crow, or was Jim Crow what made life different and miserable and dangerous? Well, the truth is always that both are true, but without the resistance, people couldn't have endured. Let me ask you, and I'm not trying to plant any hope in your voice, but do you find in this crisis now, because frankly, I don't think this issue has ever gotten this much rapid exposure. I mean, the inequalities of this pandemic, and the racial disparities involved in this pandemic have never been discussed this widely, every day, everywhere. It has become part of the top of policy initiatives and so on, we hope. Given the fact that you study this and you teach about this, and I know you teach a course that brings the story right to the present, and you just probably finished teaching that course as I just finished my course. How do you think about this right now? Is it the usual glass half full, or are you taking hope from the fact that history is full of terrible crises from which actually major change does happen? Are we on the brink of that, or is it impossible to know?
I do think we are living in a new moment. We are definitely in a new moment in terms of the exposure of these ideas that are much more accessed much more widely than before. And I think that we were moving in an interesting direction before the pandemic hit, with all of the attention around Black maternal mortality, which was raising alarm bells over and over and over again. Why is it that Black women, regardless of class, regardless of their incomes and everything else, that Black women are dying in such high numbers? And so because of that particular issue, more and more people were beginning to write about there is a problem that Black people are having in when they go to the hospital. We know from a 2002 study by the Institutes of Medicine that Black people and other minorities get lower quality of care. And this is something that is giving people a lot of pause because—
Or have no health insurance at all.
That's right. If Black women are going into the hospital and their pain wasn't being to, why is that? Why is that? And so there's these fundamental breakdowns that were happening that were getting a lot of attention. And with COVID-19, now every sort of aspect of this broken relationship is coming to the fore. And it's bringing in all of the other aspects of society, food deserts, lack of access to these healthcare centers. You can't use a drive-through testing site if you have no car to drive through. Everything that is creating conditions of greater danger and harm from this disease that's happening in certain communities, especially in Black communities who are bearing a disproportionate impact. All of these things are coming to the surface. So, what I would say is that one of the places where I see hope has to do with our role as historians. Because one of the things that I talk about with one of the things I talk about with the students I teach and when I give lectures and things at medical schools, in order to solve a problem, you need to know how long it's been going on. So, if I'm trying to, solve a problem and it happened, last week for the very first time, I'm going to approach it that way. If I know that this is something that's been going on for 20 or 30 years, I'm going to have a very different approach to it. When we think about this longer history of this dysfunctional, broken, fraught relationship that Black people have had through, this long period of time, I think that a rigorous examination of that history gives me hope, because it allows us to reckon with the fact that there are not going to be any easy fixes. But if you, as a practitioner, you are with a Black patient and you know that you're stepping into a space that has been so fraught historically, a place where there's been such distrust and abuse and neglect, then you can adjust in various ways. And I hear this from doctors and medical school students and from the pre-meds. I taught over 300 students in a lecture class in the fall, Sickness and Health and African American History, and the pre-med students are mobilizing to try to figure out how can we make this history more available, part of our formal education as future doctors, because now they can't imagine going into medicine without having fought through these particular issues. And so I think that more and more we are going to need, if we're going to have the kind of radical change that's necessary in this moment, we need a historical framework so that it can be part of the conversation. It isn't the only conversation. It needs to be a part of the conversation to help orient and ground us with where we actually are.
If I could just add, an exclamation to your wonderful point. Imagine that our students actually want to take the knowledge they get and go change the world. I mean, you didn't have to stand up in front of them and just proselytize this. You simply, more than simply, you eloquently gave them this knowledge. And then add to that, and maybe you'd reflect on this too. We're learning right now, if anyone's got one eye open, they can't, and has an open mind, which is, a question. But if they got one eye open with an open mind, they're beginning to understand how deeply we have a structural issue in this country that involves everybody. If your family doesn't know someone who's a specialist and can get you a special appointment with such and such a doctor to look at this, or if your brother-in-law is not a surgeon at the Mayo Clinic, and so on and so on and so on, you don't have the same advantages in a system of the privatization of healthcare, of a system that does not allow universal coverage. I'm not here to advocate Medicare for all or any other given policy, but I have, like you, lived in a couple of European countries for a year on fellowships and whatnot, and I know their systems aren't perfect, but I lived under the German system for 1 year and the English system for 1 year, and people didn't have the same worries that millions of Americans do, whether they got any access at all. And we're learning so much about the structural issues of who works in the service economy and so-called essential workers now. And you do wonder out there how many of these emergency room physicians and nurses assistants and so on are holding the hands of people whose families can't be there across every racial and ethnic and national origin line you can think of. The medical centers these last weeks have been, you know, a very pluralistic disaster in this society. But we probably should all do that job for one day to get this kind of lesson. Anyway, a parting shot. This you and I could talk all day about this, but a parting shot, whether it's about hope or not, or about this course you just taught. I mean, it's remarkable. Your teaching here is already legendary in just a couple of years at Yale. 300 people taking the history of medicine, of science and medicine over centuries. Any thoughts on that? I mean, you've just finished again this big lecture course. Well, you haven't finished yet because I know we're about to grade our exams. But what's that all been like?
So the class has been it's been an extraordinary experience for me. So I taught it in the fall, and the students were so passionate, and they were from all different walks of life.
And this was before the pandemic. This is before the pandemic.
This is before the pandemic. Yeah. Right. So they were, writing op-eds about these structural injustices that we're thinking about now. They were thinking a lot about the patient-practitioner relationship, as I've just been describing it in various ways. Thinking about the legacies of segregation and how those are implicated in our present. And they're thinking also about the physiological effects of racism on the body. This is a really important point that I haven't seen a lot of people really writing about very much or talking about very much, but the experiences of experiencing racism and the hypervigilance that Black people have to have in order to be out and about in the world. We don't know if the police are going to be called on us if we're, falling asleep on a couch on Yale campus, or, barbecuing, or walking into a store with a mask on. Right? Now everyone has masks on, and when people are already considered a threat or considered deviant or potentially dangerous, this has effects on the body, and these instances of racism function as a chronic stressor in our body, and it makes us more vulnerable to a lot of these chronic conditions like diabetes and heart disease and other things that are considered underlying health consequences that make people more vulnerable to COVID-19. And so with the students, what they did after the semester ended in the fall, they started an alums group. And so there are 7 student leaders that arose from this an alums group, which has over 100 students. And I had a meeting with them yesterday over Zoom, where they are talking about, publishing op-eds and working to have more conversations at Yale Medical School and possibly also at other medical schools about the importance of history and how much a course like this has meant to them. And so it's really blossoming in wonderful ways. And but our connection with history of science and medicine has a close connection, of course, with Yale Medical School and with Yale New Haven Health. And one of the things that one of our faculty was saying is that doctors that are on the front lines, they want to understand more about the social, political histories of where they find themselves. And so history is really valuable, and it hasn't been, a a sort of a normal conversation partner
Yeah.
in, with public health and with medical practitioners in terms of some of these situations, particularly concerning race, class, ethnicity. And so I do have, the students give me hope. Over
Oh, I
300
guess so.
students, they
Would that
give
every
me
course
hope.
could end like that. God, a committee of activists out there trying to spread history. My goodness. You got to bottle up that method of yours, I tell you. Well, what this tells us, of course, is that the history of this, that in the history of this, discrimination can hurt you in a developmental medical way, and racism can hurt you. It can even kill you in a developmental medical way. But without the history of that, you don't know that. You're left with naturalization, right? You're left
That's
with,
right.
well, you were born with this, or black people get these diseases, or black people are immune to this, or they get that
That's right.
disease, or white people only get that, or something.
Yes.
And even the opioid issue, demonstrated, oh my God, that was suddenly a massive white problem out in rural America. And it had to do with a lot more. It had nothing to do with race necessarily. It had to do with the circumstances of people's lives. But anyway, Carolyn, this has been fantastic. Let's do this again.
Yes.
And
Yes.
whatever subject. I want to thank you for being available to do this and sharing your research with us and your ideas. And thanks for kind of starting off this new legacy series for us. So thanks very much, Carolyn.
You're so welcome. It was such a pleasure, David.